So a lot of really very good discussions here, my disclosures. So where are these two fields going? A lot of clinical challenges and hurdles have been overcome, and finally, at least in the United States, we have approved devices, but there are two treatments that are mainstream, but they've had niche indications. So in the short term, the main activities in this field are kind of outlined here. We're really talking about broad implementation into clinical practice. The guideline updates, new device developments are ongoing, and we need more evidence to answer some of the remaining questions, of which there are quite a few, and expand indications. And as Dr. Schwartz mentioned, Canadians really got off to a great start, and this is a good summary incorporating the latest randomized clinical data. So it does give you some guideline guidance that I think will be replicated in some of the subsequent documents coming out. This is one that hopefully will be coming soon from SCI, along with the American Academy of Neurology, and it's much more about implementation of programs. Even though there are really many programs already, it gives some guidance about quality, monitoring that I think are important, and we'll expect that to come out soon. This is an outline of what's included, operator requirements, shared decision-making, multidisciplinary team, training, quality of care. So hopefully this will be published in the next couple months. This may be out in the next month. This is a European document that really is a pretty long document, really goes into the evidence in a way that is very interesting and has specific indications. And it tries to answer kind of two big questions of the role of closure versus medical therapy, and then oral anticoagulants versus antiplatelets in terms of what is the optimal medical management. And Dr. Schwartz also pointed out this recent BMJ, and there's the link. This is not a professional society related document. These are a variety of clinicians, and importantly, I think there are 3 patients that were involved in development of this. One happened to be one of my patients. The visuals are great, even though it's somewhat perhaps oversimplified in terms of the kind of workup and decision-making that goes on. It still does give a great framework and starts looking at different questions, as Jonathan said. And I think one of the important things, it does go into preferences and values. This is where the patients on the writing committee, I think, had a major play of sorting out how patients and families work through looking at the different options. This is the original, well, it's actually the updated one that came out kind of late in terms of not right before the 3 randomized trials that were positive came out. This is now being actively updated. How soon will it be published? Probably late 2018. And it's very important to see the neurologists move along with incorporation of the latest randomized clinical trials, because that's all about implementation of best practices to have that out there. Where's the PFO field going? Probably within ischemic stroke, it's really implementing what we know now and getting out there in practice and allowing clinicians and patients and families to work together to make these choices. But there is just to keep you up to date, Bob Summer is organizing a new national migraine trial. You know, we went through a very frustrating early phase of migraine PFO closure trials where there's a lot of trouble of enrollment, a lot of what sort of endpoints are appropriate, and they've come up with a very interesting way of pharmacologically assessing whether a patient may respond to PFO closure or not by using a pharmacologic agent. So fascinating, interesting approach. The big thing, at least in my opinion, going on with left atrial appendage closure, particularly from the US perspective, where we only have one device, is the need for more devices, because clearly we've seen with persistent leaks and device-related thrombus and the challenges of fitting devices to the enormous anatomical variability, some of the problems. And there is a device-to-device trial, which is an interesting way of launching the Amulet that's going on. That is a randomized trial looking at 3 primary endpoints: the safety, the clinical efficacy, and the device efficacy being the focus of those primary endpoints. And that trial's enrollment has come along quite well. So in conclusion, they really are 2 therapies in the initial period of routine use in clinical practice that has, you really see how many years it takes for new therapies to get out there. We have 2 PFO closure devices, 1 LAA. But recall, these are very targeted therapies, and much of your evaluation in the PFO realm in terms of the how confident are you that the index stroke was a paradoxical embolism goes to the foundation here. And these are fairly narrowly defined clinical indications because of the way the randomized clinical trials were organized, but there are some more clinical trials coming. We always have to be careful for kind of pushing the boundaries, especially in these therapies that are really preventative therapies. They're not going to make people feel better. And we're gathering much more data with left atrial appendage than in PFO closure in the real world, because there's no registry linked to PFO closure. And growth is different. For me, once we optimize the use in patients after probable paradoxical embolic strokes with PFO closure, migraines really the other area, but the left atrial appendage, I think, as many of the occluded areas, many of the speakers have pointed out, has a variety of ways of really hopefully enhancing improvement patient care because of the high frequency of AFib and all the different subgroups that need to be considered in the future. Thank you.